You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about cardiac masses. We'll start with an epidemiologic framework to think about cardiac masses by location in the heart and prevalence. Then we'll talk about normal anatomy. We'll talk about benign primary cardiac masses, then move on to malignant primary cardiac masses, then move on to metastatic or secondary cardiac masses, and we'll end with valvular masses. So let's start with an epidemiologic framework of how to think about cardiac masses. Primary tumors of the heart make up only 2% of all cardiac tumors. The vast majority are secondary or metastatic tumors from other organs. Among primary tumors, 75% are benign and 25% are malignant. Among the primary benign tumors, myxomas are the most common, accounting for 30% of primary cardiac tumors found in the living population, followed by lipomas at 10% and papillary fibroelastomas at 8%. Rhabdomyomas, and to a lesser extent fibromas, are almost exclusively found in children, not adults. Myxomas almost always occur in the left atrium. Papillary fibroelastomas almost always occur on a valve. Rhabdomyomas and fibromas almost always occur in the ventricles. Lipomas can occur anywhere. Among the primary malignant tumors, almost all are some sort of sarcoma. The most common are angiosarcomas, accounting for 7% of all primary cardiac tumors, followed by rhabdomyosarcoma. Angiosarcomas prefer the right atrium and like to invade the vena cava and tricuspid apparatus, whereas rhabdomyosarcomas can appear in any chamber and are often multifocal. Leiomyosarcoma and osteosarcoma prefer the left atrium. All the primary cardiac malignancies have rapid growth with frequent extension to the pericardium and have poor prognosis even despite resection and chemo or radiotherapy. Secondary metastatic tumors are 20 to 40 times more common than primary cardiac tumors. The top source of metastatic tumors to the heart are the respiratory system, lung cancer, mesothelioma, accounting for 1/3. Next, in women, 1/4 come from breast cancer. Next, in both sexes, 1/5 come from hematologic malignancies such as leukemia, lymphoma, and myeloma. Next, 1/6 come from GI malignancies such as pancreatic, esophagus, or colon cancer. Now let's think about the framework by location instead of by prevalence. In the right atrium, the most common primary neoplasm is myxoma, which is benign. Angiosarcomas, the most common malignant tumor, has a predilection for the right atrium and likes to invade the vena cava and tricuspid apparatus. Because the right atrium is the first chamber of blood return in the heart, anything that can crawl up the inferior vena cava can find its way to the right atrium, especially from the kidney, renal cell carcinoma or nephroblastoma, liver, hepatocellular carcinoma, adrenal glands, adrenal carcinoma, and pancreas, pancreatic carcinoma. Thrombus may overlay on any of the above masses. In the left atrium, the most common mass is actually thrombus, not neoplasm, especially if there is atrial fibrillation and large left atrium, prior cardiac surgery, or mitral stenosis. The most common primary neoplasm is a myxoma, usually attaching onto the interatrial septum, followed by lipoma. In patients who smoke, bronchogenic carcinoma crawls into the left atrium via the pulmonary veins. It is extremely uncommon to have any malignant primary cardiac tumor or secondary cardiac tumor in the left or right ventricles. The ventricles typically house benign cardiac tumors, such as rhabdomyomas, which occur multifocally. Fibromas occur predominantly in the left ventricle, but may also occur in the interventricular septum. The pericardium is a prime site for metastasis from lung cancer, breast cancer, and lymphoma or leukemia, likely reflecting their high prevalence in the population generally. Among the cancers, melanoma has the highest predilection to involve the heart, occurring in almost half of melanoma cases, although most are asymptomatic from the cardiac standpoint, causing malignant pericardial effusion without symptoms. It is also possible to have direct extension of tumor from adjacent lung, pleura, for example from mesothelioma, or mediastinum from lymphoma. Neither a thrombus nor a vegetation should have contrast uptake, but a tumor should have contrast uptake since tumor contains vasculature. Tumors of the valves are usually papillary fibroelastomas, especially in older individuals, although it can be myxoma in younger patients. It is quite rare for metastases from cancer or other organs to travel to the cardiac valves or endocardium. Screening. Screening individuals with disease states likely to result in mass formation, but for whom there is no clinical evidence for the existence of a mass, has a Class 2B indication for performing echocardiography. Class 1 mass-related indications for echocardiography include the follows: evaluating patients with clinical syndrome suggesting an underlying cardiac mass, follow-up studies after surgical removal of masses known to recur, evaluating patients where treatment plans depend on the results of the TTE, and assessing patients with known primary malignancies where surveillance for cardiac involvement is part of the disease staging process. That's the section on epidemiology. Now we'll briefly mention the normal anatomy. The eustachian valve, crista terminalis, and Chiari network are all normal structures found in the right atrium. The moderator band is a normal structure found in the right ventricle, and a suture line following transplant is an example of a structure in the LA that can be misinterpreted as a mass. So you have to watch out for these when you are diagnosing a mass. Now, we can talk about the benign primary cardiac masses. This is a big section. Let's start with myxoma. Myxoma occurs at a mean age of 50 years. 70% of patients are female. It is a mobile mass with a stalk attached to the atrial septum, especially the fossa ovalis. It is not as tall as the stalk of papillary fibroelastoma. It is much stumpier. In contrast, rhabdomyomas and lipomas are not pedunculated and would usually infiltrate into the myocardium itself. Myxoma should have well-circumscribed borders and be pedunculated and heterogeneous in appearance. In contrast, atrial thrombus would have more of a layered appearance rather than heterogeneous modeling, and will also be located in the posterior portion of the atrium. Myxomas present with symptoms resulting from intracardiac obstruction, systemic embolization, or constitutional symptoms. Dyspnea is the most common symptom. Syncope and palpitations are also seen. Fever, malaise, weight loss is seen in 30% of patients due to the myxoma synthesis and secretion of interleukin-6. There will be no diarrhea from myxoma, unlike in carcinoid syndrome. Myxoma is supposed to occur in the left atrium. 80% of myxomas occur in the LA. If you see a myxoma in the RA, RV, or LV, then consider whether the patient has Carney complex, which makes up 5% of myxoma patients. Patients with Carney complex typically have a gene mutation in PRKAR1A, which encodes one subunit of protein kinase A. Their myxomas are likely to recur again and again with recurrent TIA and stroke despite surgical resection. They will develop thyroid, breast, and testicular cancers. Clinical features of Carney complex other than cardiac myxoma that is recurrent are spotty skin pigmentation involving the lips, conjunctiva, and genital mucosa, cutaneous and mucosal myxoma, breast myxomatosis, primary pigmented adrenocortical disease, acromegaly, Sertoli cell tumor or characteristic calcification on testicular ultrasound, thyroid carcinoma, Pseudomonas melanotic schwannoma, multiple epithelioid blue nevi, multiple breast ductal adenoma, and osteochondral myxoma. Myxomas need to be resected due to the risk of embolization or future obstruction. Pericardial effusion is not commonly seen with cardiac myxoma. Now, we'll move on to rhabdomyoma. Rhabdomyoma is the most common primary cardiac tumor in children. It is rarely diagnosed beyond age 10, but they are still tested on adult echo boards. 75% of patients with rhabdomyoma have tuberous sclerosis. Rhabdomyomas most often come in multiple. They are found in the left ventricle or right ventricle. Rhabdomyomas are more echogenic, more bright than surrounding myocardium, and they are homogeneously echogenic. Rhabdomyomas are small and lobulated, with diameters in a range of 2 mm to 2 cm. How about fibromas? Fibromas are the second most common primary cardiac tumor in children. 10% occur in adults. Unfortunately, 25% of fibroma presents as sudden cardiac death due to its association with CHF and VT. Fibromas usually grow in the interventricular septum and less commonly so in the left ventricle or right ventricular free wall. How about lipomas? Lipomas are more common on the epicardial surface of the heart but can be endocardial. When they are in the epicardial or pericardial space, lipomas are hypoechoic. When they are in the cardiac chambers, lipomas are hyperechoic. Lipomas are homogeneous, well-circumscribed, and encapsulated mesenchymal masses, and there is no age predilection. A related condition is lipomatous hypertrophy of the interatrial septum. Lipomatous hypertrophy of the interatrial septum is a fatty thickening of the atrial septum, commonly within the posterior limbus of the fossa ovalis. It is associated with obese patients above age 60. Lipomatous hypertrophy has a dumbbell shape of the atrial septum because the fossa ovalis is spared. The infiltration of lipomatous material occurs in the inferior and superior portions. It causes no thromboembolic events. It is almost always asymptomatic, but can rarely cause atrial arrhythmias or SVC obstruction if there is massive lipomatous hypertrophy. On pathology, in contrast to true lipomas, lipomatous hypertrophy consists of a non-encapsulated accumulation of mature and fetal adipose tissue and atypical cardiac myocytes within the interatrial septum. The term hypertrophy is a misnomer since the condition is due to an increased number rather than an increased size of adipocytes. Now we are finished with the benign primary cardiac masses. We'll start talking about malignant primary cardiac masses. Malignant masses in the heart tend to be large, more than 5 centimeters, have rapid growth and local invasion, have feeding vessels, have hemorrhage and necrosis, and the latter two features lead them to appear heterogeneous on imaging, the feeding vessels and having hemorrhage and necrosis. And they also tend to have an associated pericardial effusion that is malignant. Rhabdomyosarcoma, which is a cancer of striated muscle cells, has no chamber preference. Angiosarcoma, which is a cancer of endothelial cells, prefers the RA, right atrium. Leiomyosarcoma, which is a cancer of smooth muscle cells, and osteosarcoma, which is a cancer of bone-producing cells, prefer the left atrium. Fibrosarcoma, which is a cancer of fibroblasts, prefers the pericardium. Let's start with angiosarcoma. Angiosarcoma is the most common primary malignant cardiac tumor. It presents in the 30s with a male predilection. While other sarcomas have an equal gender ratio, angiosarcoma has a 3-to-1 male to female ratio. Angiosarcoma prefers the right atrium and often affects the tricuspid valve and pericardium, and sometimes even the RCA. Angiosarcoma is highly aggressive, with a high likelihood for metastasis by the time of presentation. It usually presents as a right-sided heart failure or cardiac tamponade. It will appear as an echogenic or bright nodular or lobulated mass, well integrated into the right atrial wall. There is often pericardial involvement, either in the form of effusion or extension. Liposarcoma will appear as a large infiltrating mass in the artery. The pericardial involvement can be fatty nodules or an effusion. Liposarcoma does not respond well to chemotherapy. Leiomyosarcoma are derived from smooth muscle cells. It may originate from the smooth muscle cells lining the pulmonary veins. Treatment is radical surgical resection, chemo, and radiation. Cardiac leiomyosarcomas have poor prognosis, with mean survival after surgery of less than 7 months. Leiomyosarcoma prefers the left atrium. Unlike myxomas, leiomyosarcomas may originate from the posterior wall of the left atrium and involve the pulmonary veins, whereas myxomas attach to the interatrial septum. Patients with leiomyosarcoma typically present in their 30s, a decade younger than with the other types of sarcomas. Synovial sarcoma is caused by a translocation between chromosome 8 and the X chromosome. It is extremely rare and has poor prognosis. Those are the malignant primary cardiac masses, mostly sarcomas. Now we'll move on to the metastatic or secondary cardiac masses. Secondary or metastatic tumors are 20 to 40 times more common than primary cardiac tumors. 9% of metastatic cancer patients have metastases to the heart. 60% of cardiac metastases involves the pericardium, presenting as effusion or tamponade. 33% of cardiac metastases involves the myocardium, presenting as arrhythmia or heart failure. Among the cancers, melanoma has the highest predilection to involve the pericardium, but in terms of metastatic tumors that involve the cardiac chambers and walls, as mentioned in the epidemiology section, 1/3 come from the respiratory system, such as lung cancer and mesothelioma. 1/5 come from hematologic malignancies, such as leukemia, lymphoma, and myeloma. In women, breast cancer occurs as an etiology somewhere in between the lung cancer and the leukemia in terms of prevalence. And then 1/6 come from GI malignancies, such as pancreatic, esophagus, or colon cancer. It is uncommon for thyroid cancer to metastasize to the heart. Kaposi sarcoma, a malignancy in AIDS and other immunocompromised conditions, involves the heart in 12 to 28% of cases. Metastatic melanoma involves the heart in more than 50% of cases. Charcoal heart is the most common cardiac manifestation of melanoma, with tumors strutting the pericardial surface. Intracavitary masses can present with hypercoagulability, valve dysfunction, or blood flow impedance. When an RA or RV mass is identified, be sure to interrogate the IVC in case it is an extension of a tumor or thrombus from outside the heart. Now, we'll end with valvular masses. Other than papillary fibroelastoma can be nonbacterial thrombotic endocarditis, Lambl's excrescence, fenestrated aortic valve, blood cysts, and cardiac hemangioma. Let's talk about papillary fibroelastoma, which is by far the most common valvular mass. PFEs account for 85% of valve-associated tumors. Among all the primary cardiac tumors, benign and malignant, PFEs are number 3, right after myxomas, which are number 1, and lipomas, which are number 2. Papillary fibroelastoma is more likely to be present in patients who have had prior surgery, radiation therapy, or hypertrophic cardiomyopathy. 20% of patients with papillary fibroelastoma actually have 2 or more papillary fibroelastomas. These can be thrombotic because their microscopic structure is like that of a sea anemone. They can catch platelets and stimulate thrombus formation. They can also break off themselves. Surprisingly, papillary fibroelastomas don't cause valvular regurgitation or stenosis. Papillary fibroelastomas are usually small, less than 1 centimeter mobile masses with independent motion. They are attached to the endocardium via a stalk 95% of the time. The presence of the head plus stalk distinguish papillary fibroelastomas from fibrin stans and Lambl excrescences. The median diameter of papillary fibroblastom is 8 millimeters. 95% of valves are able to be preserved after resection of PFE, so these patients do well after resection. PFEs occur on the aortic valve more so than the mitral valve and much more so than any of the right-sided valves. 95% of PFEs are found on valves, but in less than 5% of cases, they can appear in other surfaces like the chordae tendineae, papillary muscle, or atria. 30% of PFEs are missed by TTE and only found on TEE. There is a 1.6% risk of recurrence after resection. Surgical resection is indicated for PFEs if the PFE has led to a stroke or if there are complications directly related to tumor mobility, such as coronary osteocclusion, or if the PFE is highly mobile or large, more than 1 centimeter. Observation and serial echo is okay for asymptomatic patients with immobile, small, meaning less than 4.5 centimeter PFEs. What do you do when you detect a PFE by echo? If there are symptoms such as stroke, or if the PFE is left-sided, if they are a surgical candidate, remove the PFE. If their SCS risk score is high and they are not a surgical candidate, then give antiplatelets. If the PFE is right-sided, thus making a low stroke risk or asymptomatic, then you can consider antiplatelets. Now, let's briefly mention Lambl's excrescences. Lambl's excrescences are thin, highly mobile strands that occur on the closure margin of the aortic or mitral valve. They are common, occurring in 46% of asymptomatic middle-aged volunteers. Their prevalence increases with age. Lambl's excrescences, these highly mobile strands that occur on a closure margin of the aortic and mitral valve, do not cause neurologic events. They can occur in clusters or multiple valve cusps. How about fenestrated aortic valve? Like Lambl's excrescences, fenestrated aortic valve also occurs with age and are almost always asymptomatic with no embolic events. This is a degenerative condition. These are single or multiple bright linear echo densities on the aorta side of the aortic valve. They are more echo dense in contrast with Lambl's excrescences, which are thinner and more filamentous. Next, nonbacterial thrombotic endocarditis. This is a sterile deposition of fibrin and platelets on a valve. NBTE occurs in 3 types of conditions: cancer, especially of the lung, breast, or pancreas; inflammatory conditions such as lupus, RA, other connective tissue disease, Behçet's disease, HIV, or COVID; or hypercoagulable states such as antiphospholipid syndrome or DIC. They usually occur on left-sided valves. BTE typically affects 2 leaflets of a single valve, causing kissing lesions. They are sessile, mobile, and attached to a valve without a stalk, unlike papillary fibroelastomas. NBTEs can cause regurgitation and can cause recurrent embolism. Now, blood cysts. These are thin-walled cystic lesions that are multi-lobed and attached to the valve leaflet. Blood cysts have an echolucent core, so they remain black when you use contrast enhancement agent. Occasionally, a blood cyst may have a channel inward to the cyst, so you might see contrast in the cyst. Finally, caseous calcification. Caseous calcification, which has a prevalence of 0.07%, is also known as a toothpaste tumor due to its composition of a putty-like admixture of fatty acids, cholesterol, and calcium. Caseous calcification occurs on the posterior mitral annulus and tends to be rounded in appearance with smooth borders. Caseous calcification occurs most commonly in patients who are elderly, hypertensive, or women. We have now reviewed the epidemiology and location of cardiac masses. We've talked about benign primary cardiac masses, malignant primary cardiac masses, metastatic or secondary cardiac masses, and valvular masses. That's all for this episode.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.